I'm Dr. Smith. I know a lot of you from treatment, but I'd like to welcome the others too. This is a subject that's very near to my heart. I went to treatment in 2009 myself for alcohol and drugs after being a family practice doctor for 26 years in West Virginia. So actually I thought I knew a little something about disease. I've been a doctor for a long time. I got to treatment myself and they said, "Oh, well, you have a disease." And I went, "I drank too much. I'll give you that." And I got hooked on pills. I had a sample cabinet full of them. That could happen to anyone, right? No, it doesn't happen. Turns out it doesn't happen to anyone. So that's what we're going to talk about today is what was it that happened to me? Why did it happen to me? What portions of my brain and my body were affected that I was making those decisions, and what did it take to heal my brain? And that's what the talk's about today. This is primarily, we're going to talk about something called the dopamine reward system. Now, we're going to go into it a whole lot, and I also have a book that we're going to hand out at the end that goes through all these, so you don't have to be too worried about notes or illustrations because they're in the book. This system goes to work in the very first few hours of life. The infant's born, gets cleaned up, put into the nursery, wrapped up, and in a couple of hours that baby's going to start crying. All the moms in here usually know the answer. Why does that baby start crying? He's hungry. Do you think he's going, "Damn, I want a cheeseburger"? How's he feel? How about restless, irritable, and discontent? Because it's his survival mode kicks in. See, that baby has been getting glucose from mother anywhere between 110 and 120. All of a sudden, it plummets down to 60. So we're going to talk about in a little bit what bells and whistles go off in this little infant to cause him to become restless, irritable, discontent, and then what do we do for him? We feed him, give him breast milk or formula. When we give him that breast milk or formula, he's good. So here's what happens. In this portion of the brain, the midbrain, a chemical called dopamine is released. We'll say dopamine. And when his blood sugar had dropped down to 60, his dopamine levels were very low. When he gets glucose through breast milk or formula, he gets a bump of dopamine almost up to 200. And that gives him comfort and ease and relaxation. The bells and whistles quit going off. He's not going to die. So he's good for a few more hours, and then the same sequela happens over again. The blood sugar drops again. He becomes restless, fussy. We give him formula, milk. This dopamine just keeps going like this, up, down, up, and down. And it turns out there's other life-sustaining events that this happens in. When we're thirsty and we need water or fluids, the same thing happens. When we escape danger as we get a little older, when we escape pain, anytime we get relief, when we have sex, a species-sustaining event, anything natural never goes over 200. And this just continues on through our lives until, for many of us, even early adolescence, sometimes even younger, mind-altering substances enter the picture. So whether that is alcohol, cannabis, opiate pills, benzodiazepine pills, cocaine, methamphetamine, any of our substances of addiction, or I like to term them mind-altering substances, get involved, something special happens. What happens is a larger release of dopamine. For example, alcohol, 400. That's 2 times any natural reward we've ever experienced. Cocaine, heroin, 600 to 800. Meth or Adderall, Vyvanse, 1,000. IV methamphetamine, 3,000. So what we have, these addicting substances, substances of abuse, mind-altering substances offer anywhere from 2 to 15 times anything natural that was going to sustain life for us. So the brain logs that in as this wasn't just very important, this was extremely important. This was more important than eating when I was hungry. This was more important than drinking fluids. This is more important than escaping danger. It was logged in as extremely important, and our brain remembers that. Now, this happens to anyone who uses these substances, but I promised you a little while ago I would tell you why this happened to me and why it happened to you or some of your loved ones. The ability to accept these massive releases of dopamines we now relate to risk factors. You know, for example, I always use the example, if I go into an ICU anywhere across the country and I see a patient in there who's had a heart attack, I say, well, did anyone in your family have a heart attack? Yeah, my grandpa. Do you smoke cigarettes? Yes. How about have high cholesterol? Yes. What about diabetes? Yes. What about high blood pressure, hypertension? Yes. You never go into an ICU and see one who has none of those risk factors. It doesn't happen. The same's true in rehab. We don't see patients who don't have risk factors. Our number one risk factor for who can accept these massive releases of dopamine, and I like to actually call it a vulnerable, DA, reward system. Our number one risk factor is family history. If you have a first or second order relative who has a history of problems with alcohol or drugs, you have at least a 50% chance of having it yourself. So whenever I give this talk to junior high kids or high school kids, I always say, if the plane from Miami to Atlanta crashed 50% of the time, would you get on it? That may be no different than having champagne at your cousin's wedding if you have family history of addiction. May be no different than taking an Ambien from one of your friends for sleep. May be no different taking a Xanax from someone. So people who have this particular risk factor is my highest group. 50% are at risk for the disease of addiction with family history. Number two risk factor, age of early use. Quite often I get patients who started smoking cannabis age 9, 10, 12, maybe even started alcohol 9, 10, 12. This system doesn't mature till age 24 or 25. It certainly is at risk when it's given massive releases of dopamine from these chemicals young. So your risk factor of becoming a person with addiction is much higher when you started as a teen or preteen or any time under age 20, 25. Certainly very common that I see this risk factor. Adverse childhood experiences, being exposed to emotional trauma, physical trauma, sexual trauma, any sort of abuse as a teenager or a preteen, bullying, someone giving you verbal abuse, all give you this risk factor of adverse childhood experiences. And in the book, I actually have a table that lists items that qualify as adverse childhood experiences. A high tolerance is also a risk factor. While in our society it's actually looked at as a macho or adultish quality to be able to consume 2, 3, 4, 5 drinks and still remain functional, it exposes the brain to more milligrams of the chemical, or for example, if it's alcohol. So high tolerance is also a risk factor for who's going to develop a problem with the dopamine reward system and who has the vulnerable dopamine reward system. And dual diagnosis. Anyone who has psychiatric diagnosis of anxiety, depression, bipolar disorder, attention deficit disorder, schizoaffective disorder, any of our psychiatric diagnoses, if you have them, you have a much more likelihood of having a vulnerable dopamine reward system. So we were talking about things that happen with this dopamine in this portion of our brain, the midbrain. There's actually several structures in here. One's amygdala, there's the hippocampus, ventral tegmental area, several other anatomic sites there, but this is where this happens. Now it turns out that people who don't have these risk factors, one of the reasons that they don't develop this disease has to do with D subtype 2 receptors in this area. And it turns out they simply cannot receive the reward from that massive release of dopamine that occurs with these chemicals. Easy to spot these people. Go to a restaurant and you see someone there with a margarita and you say, hey, it's a special night. We're going to bring you a pitcher of margaritas. And they go, no thanks. You say, why? Why wouldn't you want a pitcher? Well, I don't like the way 4 or 5 makes me feel. I promise you, anyone with substance use disorder never said that. And it's because they do like the way it makes them feel. They can't accept the reward. The other 90% of the population simply don't have the right amount and areas of this particular receptor to accept them, so they're not vulnerable. And actually they look at us with substance use disorder and say, why do you do that? I've drank alcohol myself, it didn't do that to me. You're right, it didn't do that to you, but it does it to about 10% of the population. Once I learned this much of the science, I actually understood, 1, it was a disease, and 2, I had it, and what in my history were many of these that made me vulnerable to get it. But you know how that little infomercial used to be on OxyClean where the guy says, but wait, there's more? All right, but wait, there's more. When someone uses these substances over and over, something else happens in the brain, and that's why I put this up here. Prefrontal cortex. When this dopamine reward system becomes dysregulated because of these massive releases of dopamine that have been accepted in the brain, a phenomena happens in this portion of the brain. This is the portion of the brain responsible for our decision making. Now we could actually see this in patients with substance use disorder because the hallmark of this disease is bad decisions. But more importantly, now we have proof as to why that happens. When this area is dysregulated from these massive releases, a phenomena happens in our decision maker. And what happens is we get decreased oxygenated hemoglobin. Oxygenated hemoglobin versus deoxygenated hemoglobin have different weights in functional MRI scans. So we can actually measure the amount of the oxygen carrying hemoglobin and the lower oxygen carrying hemoglobin. So when this happens, we get decreased O2-HBG. In other words, we have a car that's not running on 90 octane gas anymore, it's running on 60. So the even more confusing part, the car still moves, but it doesn't function right. It makes bad decisions. It spitters, it spots, it misses gears. It doesn't function properly, and that's the hallmark of what we see with this disease. Yes?
So does that mean that those particular cells are dying?
No.
They're not getting oxygen?
No, they're inefficient, but they're not dying. Now we certainly have many of these chemicals that are cellular toxic, that alcohol, methamphetamine, many do kill nerve cells, but we also produce nerve cells at a rapid rate too. So the main reason we see the behaviors in substance use disorder that we do has to do with poor decision making in the prefrontal cortex. It was a good lead-in question that you asked that, though. Did it kill the cells or not? So we've got a situation where we make poor decisions, and we can't help but make poor decisions because our decision maker has poor fuel, and it can't make good decisions. And one of the first bad decisions that we make is give in to cravings, desires. We give in to our restless, irritable discontent, and despite the urging of others and despite better knowledge of ourselves, we still put in the substances. And that's due to this poor functioning decision maker. And here's our problem. Any guesses how long it's going to take that to heal? 2 years. So, for example, we get a patient, maybe they do detox 7 to 10 days. Maybe they do residential 30 days. Maybe they do PHP 60 days. Maybe they do outpatient for 6 to 8 more weeks. That's not 2 years. So if we don't have them leaving us with a good aftercare plan, a good plan of action, and I advocate for monitoring, I still want them P-tested. For 2 years, they're still vulnerable. Now, when you haven't used these substances for 2 years, as well as developed, so abstinence, coping skills that are gained through CBT, cognitive behavioral therapy, 12-step mutual support, through good psychiatric care. Certainly if you have dual diagnosis, good psychiatric care, good medical care, overall healthy living. We know through studies of physicians airline pilots and nurses all across the country who participate in 5 years of monitoring cognitive behavioral therapy, development coping skills, 12-step mutual aid, psychiatric care, and medical care. We know the recovery rate from this disease is 90%. Virtually gets close to 100. When we don't get 100, it's simply because we don't get patient compliance with one of our recommendations. For many years as a family practice doctor, I see a patient with high blood pressure. I'd explain it to them, prescribe them medicines. They come back in 2 weeks. They came back in 2 weeks, the blood pressure's good. I go, okay, anything good? Any questions? No, I said, I'll see you in 6 months. Patient comes back in 6 months, blood pressure's sky high. I said, what happened? I didn't think I needed it anymore. No different from substance use disorder addiction. Patients I admit back to detox, I usually don't ask them why you're here. I say, which one of these didn't you do? Usually they didn't do any of them. But quite often it's, no, I didn't get any cognitive behavioral therapy. I don't like 12-step meetings. Of course, I never went. I don't believe in psychiatry. I don't think I was depressed. I never go to the doctor. And I didn't get good medical care. So, the best situation that I think we can hope for when we have a patient leaving is, did we set them up completely detoxed under good psychiatric management and give them the ability to know what their aftercare needs to look like, and hopefully facilitated referral to those appropriate places so they can do it. And the bottom line, this disease does not have to have a dismal success rate. It can certainly rival any disease that we treat with 90 to 100% success if they get good care and aftercare and they're willing to be compliant.